Okay, I think we're kind of at a steady state right now, and I'm sure people will probably be popping in. So my name is Bianca Frogner. I'm a professor over in the Department of Family Medicine at University of Washington, and I'm also the director of the Center for Health Workforce Studies at University of Washington. But today I'm really holding the hat of being part of the leadership team of the new award network. And we're really happy for you all to join us today on our monthly webinar series. As many of you may be starting to attend, we are holding these monthly seminar series as a way to build community as part of the award network. We have actually just recently assembled a webinar committee, and I am serving as the head of that committee, but we have a fantastic team, including Emily Franzosa from the Icon School of Medicine, Madeline Sterling from the Weill Cornell Medical College, Hui-Wen Xu from University of Texas Medical Branch, and Jarman Ye from the Institute of Health and Aging at UCSF. And we just had our first kickoff meeting, and I'm really excited for the future series of webinars that we will have in the upcoming year. But today we have a fantastic speaker with us today, Cheney Fabius, who will be presenting on the residential service agency characteristics and care experiences of older home care recipients and their family caregivers. I will give a little bit of a background to her to get us started. She's an assistant professor at the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Dr. Fabius is a gerontologist and health services researcher with an interdisciplinary background consisting of training in gerontology, human development, and family studies, and in public health. Her research informs aging and disability policies to reduce healthcare disparities and improve health equity for older adults and people with disabilities using long-term care services and supports. Her interests are informed by applied clinical management experience, where she helped older adults remain at home and delay the need for nursing home care. Dr. Fabius completed a 2-year ARC-funded T32 postdoctoral fellowship in the Center for Gerontology and Healthcare Research at the Brown School of Public Health. And so we're really excited to have her present, and we will have her present for about 30 to 40 minutes, and then we will have a facilitated Q&A, which I will help to do at the end. And so feel free to post questions. Again, use the Q&A function, and I will go ahead and monitor that, and we'll wait till the end for those Q&A. So with that, I'll go ahead and turn it over to Dr. Fabius.
Thank you, Bianca. Thank you to the Award Network for inviting me. Thank you to all of you for joining today. I'm going to go ahead and get started. Thank you for that introduction. Just to set the agenda for today, I'm going to be giving you sort of an overview of my own work, as well as then talking about some of what many of us may be familiar with, but of course, to really emphasize and provide some context around my work, to give description of home and community-based services and the direct care workforce. And then I'm going to be presenting a study that I've done that surveyed home care agencies or residential service agencies in Maryland, and I'll talk about that in a bit, as well as the project that links residential service agency survey data and Maryland Medicaid home and community-based service recipients. So my work focuses on improving equity for older adults, family caregivers, and the direct care workforce. And I do these in 3 ways mainly. Much of this is informed by personal caregiving experience, as well as the care management experience that Bianca mentioned in my bio. But first, I describe disparities in care experiences of older adults and family caregivers using LTSS. This is done mostly through secondary data analysis, as is understanding contextual factors related to LTSS access, care delivery, and care quality. But today I'm going to be focusing on this arm of my work that I've been building and developing over the last few years to support the direct care workforce, to strengthen the direct care workforce. And that has been done through a series of primary data collection activities, and now moving on into intervention development. So, as I said, many of you on the call or in the Zoom room may be familiar with home and community-based services, but just to provide background, the goal is to delay or replace the need for nursing home services by allowing people to age in place or age in community. HCBS align with older adult preferences to remain in their communities as they grow older. And for the most part, they are delivered through states' Medicaid programs. Otherwise, they are delivered through private pay. Now, Medicaid is the largest payer of LTSS, and as a result, access to services varies by state. The availability of services, the type of services that are made available vary by state. And over the past several years, there's been an effort to rebalance Medicaid expenditures from institutions to community-based care. And as a result, we've seen a shift in sort of the priorities that states have in keeping people at home. Now, in Maryland, 56% of Medicaid LTSS expenditures are dedicated towards HCBS. So just to kind of give you an idea of where our state lands. Now, persons living with dementia comprise more than 1/3 of HCBS participants, and that's relevant because this is a growing number of folks, and there are special, if anybody has worked with families that provide care for people with dementia or people with dementia themselves, you know that one person diagnosis is one person's diagnosis. And so there are, special considerations that have to be taken when developing strong services and appropriate services for people with dementia. And so the home care services that I am interested in and that I used to help facilitate, implementation of are delivered by the direct care workforce, and these are personal care aides, home health aides who help with routine daily activities. They are the fastest growing workforce in the United States. The workforce is comprised of the home care workforce, is comprised of about 2.4 million direct care workers. There's a substantial number of others that provide services in institutions. However, their training is minimal and it varies. So for example, home health aides are often more so required to complete at least 75 hours worth of training, whereas those who are not receiving that certification, those personal care aides or attendants, it really varies. And it many times is based on what the agency is able to provide that they are working for. They're typically contracted by independent home care agencies. These are residential service agencies in Maryland. It's just the name, residential service agencies, but these are independent home care agencies. And as a result of that Medicaid LTSS financing rebalancing that I spoke about a few minutes ago, we've seen care recipients or older adults living in the community with greater disability, higher acuity, and so that places a greater demand on the direct care workforce that is providing care to older adults in the community, as well as the shifting of the availability of family caregivers. So fewer family caregivers means a greater demand for the workforce to provide care. So the direct care workforce can be seen in the way that they interact with family caregivers as support and providing necessary respite at times, but those relationships can also be strained if there is a misunderstanding of roles, a miscommunication, and the best strategies to deliver care to an older loved one or older relative. The care demands are greater when caring for people with dementia due to things such as managing dementia-related behaviors or working alongside family caregivers more and participating in other aspects of care, such as attending and advocating at doctor's visits. The direct care workforce does have on-the-ground intimate knowledge about older adults and families. Despite their intimate knowledge, though, of the health and well-being of older adults, they are often left out of conversations that take place between interdisciplinary care teams, such as those had between nurses, social workers, and even clinicians, often minimal, not always encouraged. And so there's the potential for better integrating these workers into care teams that also extends to perhaps involving them in things such as electronic health records or patient portals, which is relevant given the increasing use of technology to manage medical care. Now, just a bit about the workforce in Maryland. So between 2014, 2024, which we are almost at 2024, there are going to be, there's a need for 40% more direct care workers to meet the growing LTSS demands. There were nearly 71,000 direct care workers in Maryland in 2017. This number also included certified nursing assistants, which are not necessarily who I think of in this sample of home care workers, because they traditionally provide services in institutions like nursing homes. And then the median hourly wage for these workers was only $13.03 an hour in Maryland just a few years ago. And so you can imagine that many workers are living below the poverty line, receiving public insurance, so on and so forth. I tend to call this workforce a group of vulnerable people caring for vulnerable people. And so there are a couple of gaps, there are many gaps that, I believe the award network is passionate about addressing, and that seem to be getting a lot of attention now. But some that I chose to address in the work that I pursue is first this gap, the lack of information about residential service agencies. So there is little information that's known about residential service agencies or home care agencies that employ direct care workers due to difficulties in collecting data on agencies, as well as existing literature on agency organizational factors and care quality being primarily limited to Medicare skilled home health rather than HCBS. This is likely given the ability to assess factors such as home health quality. So there's no such general measure for HCBS, and it's because it varies tremendously, by state. It's hard to make generalizations on the national level as it relates to these home care agencies. The second gap, that there's a limited understanding of the relevance of agency level factors in HCBS participant care experiences. So the care experience of HCBS participants generally is limited to examining individual factors or care, or what you might call social support or caregiving, care environment factor or characteristics. I've done some of this in my own work. It's often limited to focus on specific programs, such as the Money Follows the Person program, that enables long-stay nursing home residents to transition from the institution to the community and receive HCBS. And I've done some of my dissertation work on this. And then there's also a minimal focus on family caregivers. Also, my former team at UConn has done some work looking on impact on family caregivers of the Money Follows within the Money Follows the Person program. And so the projects that I'm going to describe in this presentation have had two aims. This is work funded by our Johns Hopkins Alzheimer's Disease RICMAR, Resource Center for Minority Aging Research, and as well as the Bloomberg School of Public Health. The aims include surveying Maryland residential service agencies about their current practices, barriers, and opportunities to improving training of direct care workers of persons with ADRD, and then also to assess variability in Maryland residential service agencies, organizational characteristics, and older HCBS recipients' quality of life outcomes or care experiences. And so I leveraged the Convoys of Care model to think about this work. So convoys are defined as dynamic networks of close personal relationships through which social support is distributed or exchanged. The Convoys of Care model proposes that these convoys or these networks are affected by individual, social, economic, and political factors. So my adopted model or our adopted model proposes that older adults and family and caregiver experiences are a result of multiple factors, including state policy influences, residential service agency characteristics, and individual characteristics. In this case, the individual characteristics are limited to the HCBS participant. And these are and I'll talk about the outcomes that we looked at in a little bit. So the first aim was to survey these Maryland-based residential service agencies. So with that conceptual framework in mind, we first sought to gather information about residential services in residential service agencies in Maryland. And so we developed a survey to administer to residential service agency administrators. Simultaneously, while we were developing this survey, we identified residential service agencies via publicly available data from the Maryland Department of Health. So these residential service agencies are not Medicare home health agencies. That's important to remember, and they are primarily paid by Medicaid, HCBS, or private pay. And Maryland has several programs, be it state plan or waiver or community first choice, that people receive services through. But the recruitment and data collection, so we conducted a proof of concept study with the Maryland National Home Care Association. It's just a local home care association that supports residential service agencies as well as home health agencies, but they helped us think through the types of questions that we were asking and whether they were appropriate, whether they made sense, things like that. The survey, when we distributed it, it was multimodal. So we sent out a letter in advance to distributing the survey that said that, you can expect to receive a survey in a couple of weeks, just to put agency administrators kind of grab their attention and get them sort of on notice that they would be receiving a survey. We used U.S. Postal Mail to send out the surveys, and then you had the option of sending the survey back. You had the option of calling to complete the survey or completing the survey online. And I will say that only about 1% of folks completed the survey via phone. Most of our responses came from the mail or online. Once we mailed the surveys, my RAs and I followed up with 2 phone calls. If we did not hear from the agency administrators, these surveys were conducted collected between February 2021 and June 2021. So still very much COVID. And we provided each person with an Amazon gift card as an incentive. And so the survey domains included residential service agency characteristics, client characteristics, training requirements of direct care workers, direct care worker roles related to healthcare management, such as use of the patient portal or health information technology engagement. And we also collected information about dementia-related challenges and supports. We also had a couple questions about agencies' experiences with the COVID-19 pandemic. And so this is a busy slide, but I always say focus on the red. But just to give you an idea of our sample. So we had from our publicly available list from the Maryland Department of Health a little over 1,100 agencies, RSAs. We had to do some cleaning of those data. We mailed almost 1,100 surveys. We did get, some that were no contact, which we deemed as we got return to sender, and there was no call, there was no return call, or the number was disconnected. So our denominator was 1,052 agencies. There were some people that just went and poked around we used RedCap to complete the survey if they went in online. So they kind of just maybe looked at the survey but didn't complete it. And our completion, the number of completed surveys was 177. So about a 17% response rate, not outstanding, but not nothing. So, just taking into consideration that we were trying to recruit during COVID, which was a very hard time for everyone, especially for these workers and their agencies. Our analytics sample included 111 residential service agencies that employed direct care workers. So there were some that did not employ direct care workers. Residential service agencies could also be solely responsible for durable medical equipment provision, things like that. So there are some scenarios in which you may not have a home care service being provided in the traditional sense. So we had 111 residential service agencies or RSAs with direct care workers for this analysis. So for that first aim, just sort of getting the lay of the land. And I will say that the administrators that we did hear from, there was about representation of 20% of the state. So we had some folks that were sort of spread out throughout the state. They were not concentrated in one area or another. So the average number of employees, we can see there's a huge range from 2 employees to 427 employees. But the average number of employees, agency employees, was 58. There was an even split for the most part in the years of operation. There was a larger share of agencies that we categorized as small, so having 1 to 10 clients. That's pretty small, but it was a substantial amount of folks who were only serving between 1 and 10 clients. And you can also see that the range is huge between this large group, 37 to 930 clients or participants. So it's pretty evenly split between Medicaid being Medicaid financed and not. This is important for the second part of our analysis. And then we saw 2 extremes of having staff who spoke English as a second language. So more than a third of the administrators reported that 75% or greater of their staff spoke English as a second language, but almost 40% said that it was less than 25% of their staff that spoke English as a second language. So just interesting. Percent of clients who were 65 and older, about half reported that 75% or greater of their clients were 65 and older. And 40% reported that 75% or greater of care recipients had dementia. That's pretty substantial as well. And so this first table presents the direct care worker involvement in what we've deemed care team activities. So we asked about the contributions, direct care worker contribution to care plans, direct care worker role in healthcare management. Of course, this is from the administrator point of view, but almost all administrators reported that direct care workers contribute directly to care plans as well as attend doctor's appointments. Most report that direct care workers help with scheduling appointments or refilling prescriptions or interacting with clinicians on some level. About 40% reported any use of the patient portal. And this could include viewing sections of the patient portal. This could include performing healthcare management tasks or interacting with clinicians. Now, we asked administrators about the type of training required. And interestingly, dementia-specific training was the least often required type of training. I mean, it was kind of neck and neck with nutrition, but still, to see that there was such a substantial number of clients or participants that had dementia and have it be the least often required type of training was very interesting. And then this table 2, presents dementia-related challenges and supports of residential service agencies. So almost 90% of administrators reported that their staff experienced some sort of dementia-related challenge, and this included challenges managing dementia behaviors, issues communicating with clients with dementia, issues with family, or as well as issues with family, including communication. And then about 70% of administrators reported that their agencies offered supplemental dementia-related support. So that included family caregiver dementia training, referrals to other supportive services, and information about other supportive services. And so this first aim just Surveying Maryland residential service agencies showed that there's tremendous heterogeneity among residential service agencies. I want to highlight again that while administrators reported that agency staff experienced dementia-related challenges, that dementia training was the least often required training. And there has been a lot of recent ideas around the care team integration and calls for the consideration of potentially involving direct care workers in health information technology. Our findings show that they're accessing patient portals for various reasons already. So it might be worth taking a better look at what that might look like in a formal procedure. So the second aim I'm going to transition to was to assess the variability in Maryland Residential Service Agency's organizational characteristics in older Medicaid HCBS recipients' quality of life outcomes. And this has actually been published in a special issue of the Journal of Applied Gerontology that focuses on the home care workforce. And this work was to address that second gap. So our limited understanding of the relevance of agency level factors in HCBS participant care experiences. So we linked a subset of our data, our survey data, to Medicaid HCBS recipient data. So we leveraged our survey data, and through a collaboration with the Hilltop Institute here in Maryland, we linked survey data to Interi home care assessment data for older adults who are receiving services through the Maryland Community First Choice plan or state plan. The Interi home care assessment is like an OASIS version for Medicaid HCBS. It's completed by RSA nurses on an annual basis. It collects information about HCBS participant function, social factors, caregiver burden, healthcare utilization, and it's used to track those changes that might warrant revisions to participants' service care plans. And so this is the same chart from earlier, but I highlighted the sample size that's relevant to this paper. So there were a couple other exclusions that we had to make. Of course, if these aides, so remember the first part of this project, we surveyed everybody. So we had to remove those that were not Medicaid vendors or Medicaid financed agencies. And then those that were not providing services to older adults. That was done through identifying folks in Hilltop. So we landed on 25 agencies that were providing services to over 1,100 older adults age 65 and older, with an available Interi home care assessment that was completed in 2020. And these are all measures from the Interi. So participant care experiences. So the three outcomes we were interested in was low social engagement. So we defined that, or it's defined as, some of these were recommended by Hilltop by how the state also measures these outcomes. So 30 or more days since being last able to participate in social activities of longstanding interest, hospitalization any of the last 90 days, emergency room visit any of the last 90 days, and then caregivers' care experiences included feeling overwhelmed by the participant's illness, yes or no, expresses feelings of distress, anger, or depression, yes or no, and unable to continue caregiving, yes or no. And so these are our measures that we also included. So we have the participant characteristics from the Interi that included age, gender, marital status, race, ethnicity, dementia on a score that we categorize as a score of 12 or less on the BIMS. And then the residential service agency characteristics we pulled from the survey. We didn't include everything that we had, but agency tenure, the number of participants, or percentage of participants age 65 and older, dementia-related challenges, all the way through to dementia-related supplemental services. Our analysis was descriptive. We use Pearson chi-square and students t-tests when appropriate. And so this first table show that those with dementia, and I will say follow the yellow to see the statistically significant findings. So those with dementia were more often older, Asian, Hispanic, or other, and had greater disability. We saw no differences in participant care experiences, but people with but the most experienced care experience was low social engagement. So there's a substantial number of people experiencing low social engagement, over 60%. And then caregivers of those with dementia were more often overwhelmed, distressed, angry, depressed, or unable to continue caregiving. But it should be noted that the rates of difficulty were low among caregivers in our sample compared to the general population of caregivers. This second table presents residential service agency characteristics by participant dementia status. So those measures that we took from our survey across the dementia status, so those with and without dementia. So those with dementia were more likely to be receiving services from agencies where workers helped in the patient portal or with health information technology, especially viewing sections of the EHR or the electronic health record. And they were also more likely to be receiving services at agencies that provided supplemental services. Table 3 presents residential service agency training and supports. So here we looked at how care experiences varied for each of these, the types of training that residential service agencies reported offering or providing. So participant experiences of low social engagement and services use were higher among agencies that required direct care worker training and support. So we can see that across those that provided dementia-specific training, those where the agencies were assisting with health information technology, those that offered supplemental services, the participants, the receiving care from those agencies were more likely to experience low social engagement. And that held true for those receiving services at agency that had dementia-specific training for hospitalizations as well as emergency room visits. And similarly for caregiving experiences, not quite as much that was statistically significant, but those that were receiving, those recipients that were receiving services from agencies that had direct care workers helping with health information technology, or those that were receiving services with supplemental services were more likely to have caregivers that were overwhelmed. And so just to sort of summarize, our findings support earlier work that highlights the vulnerable nature of community dwelling older adults. So just to highlight again that 60% of the HCBS care recipients in our sample experienced low social engagement. And while this did not vary by dementia status, still considerably high. There are opportunities to better include or engage direct care workers in interdisciplinary care teams. You know, we looked at sort of this engagement in the portals, but we also asked questions early on about, you know, involvement in care planning and things like that. And so there just were some places that probably we could look into a bit more in terms of opportunities for engaging direct care workers. There are benefits of Medicaid HCBS for family and unpaid caregivers. So there were relatively low rates of negative experiences, lower than we would expect to see in the broader population of caregivers, lower than I've seen in my own secondary analysis work of nationally represented samples. And then care experiences, not surprisingly, varied by dementia status. This is not surprising, but still warrant the need for novel strategies to support older adults with dementia who are HCBS care recipients. Several limitations. Of course, these are the experiences of HCBS participants and caregivers in one state. We had a low survey response rate, but again, some of that, I believe, a lot of it was due to COVID. We did encounter several agencies as we were collecting data that actually closed during the pandemic, and they just happened to still have their cell phones on. But if you think about, then some of those agencies are really, really small, so they're low resource likely as well, and so that might have contributed to our low survey response rate, as well as the sheer number of responsibilities that people had during the pandemic. Just the overwhelming demand for continuing to work in a safe way during the pandemic might have contributed to our low survey response rate. Might not have been interested in completing a survey. We're unable. So one limitation is that we're unable to determine whether surveys, the NRI assessment, were completed with the assistance of or solely with the caregiver. So those caregiver questions, you cannot delineate who responded. So if the caregiver was there, they were likely to have responded. It's also possible that the older adult responded on their behalf. So that is a limitation. And they were unable to determine the amount, frequency, and type of services older adults are receiving. That information was not available to us. So in conclusion, from both of these aims, there is the potential to strengthen the care delivered by direct care workers in community settings. Family caregivers are integral to the success of home care delivery, and thus we should, make the effort in making sure that those lines of communication or information sharing, or however we describe it, between family caregivers and home care aides, the agency, that they're a bit more fluid. At the moment, they're very fragmented. The findings that we have laid the foundation for future longitudinal and embedded interventions aimed at improving home care delivery, which is sort of the direction that I'm moving in now. And then the strengthening of HCBS is integral of policymakers and providers to support families and the community. I just wanted to highlight some of the community engagement activities that we've continued as a result of this work. So we recently just shared this newsletter with our survey respondents. So those administrators that responded to the survey received the findings in newsletter format. We shared it with some the folks from the Home Care Association that we partnered with. We've presented to that home care association just to continue to nourish that relationship and remain connected. And this work, I mentioned that it was pilot work, but it was used as preliminary data for 2 career development awards. The first was from the NIA Impact Collaboratory. I was awarded a career development award in 2021. We're now analyzing this data, where we conducted qualitative interviews with agency administrators, nurses, and direct care workers to better examine ways, to better engage direct care workers in care delivery for persons living with dementia, with an eye toward understanding some strategies or brainstorming strategies for an eventual embedded, pragmatic clinical trial. And then these data were also used as preliminary data for a newly funded K01 that I received that just started January 2023 to continue this line of work, to conduct a feasibility study of an intervention to strengthen information sharing between family caregivers and direct care workers, also to clarify roles, because that's something that continues to come up in terms of misalignment between caregivers and direct care workers. But this is going to be for older adults receiving Medicaid home and community-based services in Maryland. And so I just wanted to acknowledge, of course, my amazing mentors, Dr. Jennifer Wolf, Dr. Joe Gallo, Dr. Deirdre Johnston, my collaborators, so MINCA, the Maryland National Capital Home Care Association, the Maryland Department of Health, the Hilltop Institute, Leading Age, so Robin Stone, Natasha, have really sort of helped contribute to the thinking and ideas around some of this work. And then my funding sources include the Impact Collaboratory, the Rick Marr Center here at Hopkins, and the Bloomberg School of Public Health. And I have my references on the last slide, but I will stop here and take any questions or feedback that you all might have. But thank you again for having me and letting me share this work with you all.
Well, thank you so much, Dr. Fabius, for a wonderful presentation and for really kind of sharing with us kind of where this sits in your broader portfolio of work. And I also want to congratulate you on your KO1 award. That's
Thank
really
you.
exciting that you're able to continue on this work. And please, for folks in the audience, again, if you have any questions, please feel free to put it into the chat, or sorry, into the Q&A box. There is no chat function. Otherwise, that's here. And again, this presentation has been recorded and will be available on the Award Network's website, which is new and can be found at awardnetwork.ucsf.edu. So I just want to maybe kick it off with a couple comments and questions that are in the Q&A box. So one was from Vernette Mahoney. I'm sorry if I'm pronouncing the last name incorrectly. And Vernette mentioned that in Michigan, they saw the same goal of replacing nursing home care for those who chose to stay in their home and community. So maybe if I can just add to that is, could you speak, Dr. Fabius, a little bit to how Maryland compares to what other states are doing? Is Maryland considered a leader in this space, or how are there other states that you're looking towards and seeing what they're doing and watching what's happening?
Yeah, well, the one challenge that many states face, so I think Maryland does okay, but I think one of the challenge that Maryland and other states face is that there is an overwhelming demand for services because of this sort of reorientation towards home and community-based services, which is great. I love to have folks age in the community. What happens is that you encounter long wait lists. So, for example, waiver, home and community-based service wait lists can be a couple months, they can be a couple years. In Maryland, for example, the wait list for waiver services is a couple of years. And so that's a major challenge and limitation for having people age in their community. I think that there is work that states like California are doing that really help strengthen the direct care workforce and sort of engaging them a bit more in the ways that I sort of talked about. So there are probably a few different strategies that different places are doing that both, number one, keep people at home, but also support the direct care workforce.
Great. And so another attendee first wants to say thank you and say great presentation, which I certainly agree. So the attendee first mentions that they're a bit dumbfounded that the providers did not think dementia care education was needed as much as like the other types of education. Why do you think that might be the case? And was it because of COVID and the need to focus on infection control? What do we need to do to move forward?
Yeah, it's just it is interesting. I thought that that was the case. I think when speaking with a couple of administrators, and again, that's a couple of administrators, but these are the people that are on the ground, is that dementia training can vary in how you're able to access it. There's a bunch of different models. It's hard to demonstrate its effectiveness outside of improved knowledge of dementia, which is important. But most of what I heard, was that one person with dementia is one person with dementia. And so it really is a matter of home care aides and their whole care team learning that person. And so like the book knowledge that you gain is not always applicable to situations that are, be it an emergency, be it just personality. So I anticipate that that's some of, the reason behind the lack of training. We kind of champion for training in the research world. It's like they need more training. But I think that, we have to do a bit more strategizing around what makes sense in terms of training, how often we should train, the amount that they receive, and so on.
That's great. And if I could just follow up with a couple of questions around training, because I certainly have a strong interest in career development or professional development, and training can fall into that category of professional development. So one is whether maybe if you could speak a little bit to how you see training as part of the professional development of the home care aides generally. Is this Do you see as a pathway towards, say, either higher wages or a pathway to a different career, or have you seen ways that this elevates somebody's career, either with supervisory roles or anything like that, whether it be dementia care or other kinds of training?
Yeah, it's interesting. I think that in the qualitative interviews that we've done, there has been a feeling that folks are receiving adequate training, and training in the sense of I feel prepared for my job. Like the care that I deliver is good because I'm a good caregiver, but also because I did receive this training, and not specific to dementia, but the training that these agencies provide. The challenge is that, the workforce experiences, and we see high turnover just because of, low wages, lack of support, the list goes on. I don't know that training for it might extend the time that somebody's there if there is an increase in wage associated, but I also don't expect that people will make a career oftentimes out of this direct care work. It's challenging work. It's often a means to get to another sort of position, or a stop along the way for folks, or people are returning to the workforce and doing it. I think that the training, if it leads to some sort of certification that improves wages, that is part of a certain sect of the home care's career goals, that is helpful. But in a sense, and mainly training, I think, is to benefit the care delivery, the person that is on the receiving end of the services, the care recipient.
Sure. Well, that's thank you for that answer. And I noticed that there was a bit of some differences in the outcomes that are related to engagement with the EHR systems and the patient portals. And I mean, in the rest of the healthcare system, we're trying to get more technology, I guess, into the system to help patients. Are you seeing any promising technologies, even outside the EHR kind of realm, that might be helping direct care workers do their work? Or do you see that the patients or their caregivers demanding any of this?
Yeah, so in the qualitative study that I've done with the Impact Award, everyone spoke about a different model or software that they were using. So the challenge is that the systems often don't talk to each other. So you talk with one home care aide and or one home care agency, and the administrator, is using this, this electronic management or healthcare management software. You talk with another and it's a different one, and they all do different things. Some are really just interested in capturing times, so checking in and out, clocking in and out, things like that. Others allow home care aides to provide like a note at the end of each service. Others are part of a larger system that they can sort of circulate around, families and caregivers, but they're all doing such different things, and have different values and ideas around what's important and whether they want to be connected to those sort of clinical providers. That it's hard to say, but to me, our findings have shown that, at least as it refers to the patient portal, direct care workers are already doing some level of engagement with it. And so if there was a way to better connect them to the patient portal, and in Maryland, I'll just say that doctors do not have to provide an order for these private pay or Medicaid HCBS. And so the challenge is that you have family caregivers, you're relying on family caregivers for them to pass down healthcare information, which is not a bad thing, but it's not always accurate, or, it may change. And without being directly connected to the person's clinician, you are often behind the ball and knowing if there are changes in medication administration, or the meds have changed, or if there's a new recommendation for a regimen, things like that. And so if there was a way to tie these pieces together, I do see potential in that. I do think it will take a while to, be strategic as well as fair in terms of what direct care workers are able to see and access. We're just starting to get there with family caregivers in terms of giving them access in some way, shape, or form to portals, and encouraging people to use them, because there are there's racial and ethnic, for example, disparities in who accesses patient portals. So there are a lot of sort of touch points, but I do think that there is potential to think more strategically about that.
Great. And I'm curious, given the large immigrant population among, especially our healthcare workers in this space, how much do you think language is potentially a barrier? I mean, are there opportunities for translation, interpretation, any of that as part of the work that's ongoing?
We didn't dig further into language, but even as, I've been describing sort of the overall survey and just like the substantial number of staff that were speaking English as a second language, I think it's really relevant to the care that's delivered at home. Eventually I am going to be interviewing family caregivers and people with dementia. I think that that's part of the question too, is like that congruence between the family caregivers, the people that are receiving services and their home care aide. And I know language is a big part of that. If, so many workers are speaking that it just might be a challenge that the family unit, as well as the workers and the agencies have to overcome.
Great. And I do want to just share that an attendee said, thank you again. And this was a well done presentation, and that while they're residing in another state, this work is significant to what they're doing in that state too. And then I don't know if it's the same anonymous attendee or a different one, but they mentioned that as the world is changing, do you see any potential correlation with potential challenges in getting the diagnosis of dementia and when families can access home care services? Also, do you think that that may have deterred families after trying so hard to get it, that they end up placing loved ones in those facilities? So I guess it's the timing of the diagnosis of dementia that may be determining home care versus, say, nursing home. That seems to be a question.
Yeah, it's possible. I mean, the home care services are eligibility is usually determined by your functional ability. So if there are already signs that there is a need for assistance with your activities of daily living, bathing, dressing, so on and so forth, and instrumental activities of daily living, that's usually probably the time that you want to really have someone, either try to enroll in services. What I will say is, while the Maryland waiver services do have the wait list, you can receive sort of services through the state plan and things like that, so that you're not completely, and the state plan has no limit, like people who meet eligibility have to receive services. You probably won't get as much as you will get with the waiver, but there is some assistance that you receive. But yeah, I do think, people who receive dementia diagnoses late, but also that sort of feeling that, we can just manage this ourselves. If you try to sign up for services and they tell you that you have 7 years till you're going to be, receiving them, you might feel like you're kind of on your own and managing someone's care. And so we may see a bunch of things going on in that realm that end up having someone placed in facilities eventually.
Great. And I know we're kind of coming closer to the end of the hour, and maybe if I could just ask you if there are any lessons learned in this process that maybe you could share about either studying this population or something about the experience that you've went through in studying this that you hope to apply in your future learnings, but also that others in the audience might be able to learn from your experiences if they want to dive into this area.
Yeah, I think, I knew this already just through my care management experience, but just having it sort of re-emphasized is that the delivery of home care, and I'm sure this applies to others, is just so different depending on the agency that, depending on the state and depending on, what's available. I had to create, as a professional on the other side of things and a researcher, a roadmap of how to get, how people are placed into services, how they end up being eligible, what makes them eligible, how they enroll. And so I can't imagine I can, because we've done it in the past in my family, but, having to navigate that from the caregiver perspective can be very overwhelming. And so there's that piece. There's also the piece that the home care agencies, especially now with COVID, are really overwhelmed with, trying to safely deliver home care, not being and maintaining a safe environment for their workers. I think, didn't surprise me, but there's something that stood out that, is a huge concern, is just to make sure that they continue to provide quality home care. And then I think some of the contradictions that we saw in our findings, with the dementia training, but, most people saying they did have some dementia related challenges, or that, a good share of folks had, most of their clients or care recipients were living with dementia. It's like, there has to be something else that we can do, right? That will help address some of those challenges that they have. So I'll stop there. There's probably more that I could say, but those are some of the things that really stood out to me.
Well, this was really a great presentation. And again, this presentation was recorded and it will be available on the Award Network website. So that's at awardnetwork.ucsf.edu. And you can also, we'll also announce that on social media, where you can find the Award Network at @award_UCSF. But thank you so much for this presentation. I know audience members are also kind of mentioning in the Q&A, thank you for doing this great work. It's great to see what's happening at the state level, and people are hoping that maybe there's going to be more national conversation around this, more national efforts, more states that might do this kind of work, because there's certainly challenges that many states are facing very, very similarly. Right. So hopefully we can learn from the great work that you're doing in Maryland. So thank you so much for taking the time, and thank you for the National Institute on Aging for funding this webinar and this network. So again, and thank you to everybody here for joining today. So have a wonderful day, everybody.
Thank you for having me.